So I'd like to have a look at some of the things that happened in this pandemic, what has worked, what didn't, and some of the things that we've hopefully learnt. So I've been around a fair while, with the pleasure of chairing the Immunisation Coalition, previously been a member of ATAGI, and no one knew what that was 10 years ago, but most people have heard of it one way or another. So I'd like to just reflect a little bit on what it felt like being at the front line. And a lot of people have talked, saying it's a bit about being at war. There's a lot of complex issues. So the people we're seeing in primary care are coming to us with a whole lot of information, and they're looking for us to turn it into practical and pragmatic solution. But there's a lot of anger and concern about how they've got their information. So when they arrive and they talk to us on a one-on-one basis, there's a lot of tension. So looking around, so I've got this just to remind us that this is a rapid fire event, but this is a more up-to-date rapid fire piece of equipment that the front line of the Australian Army is using. So it's interesting to reflect as whether we're prepared as primary care group, or are we using something from World War I? So it's important to make sure that we're skilled and appropriately armed. Make sure we're properly equipped. We need to be properly trained. We need to know what the enemy looks like, and we need to adapt to the situations that we find ourselves in. So when it comes to the face-to-face consultations, we're getting our information, but our patients are asking us to look at it. So on the right-hand side of this screen, it was in red, but it didn't come out. But this is us consulting with our patients. And the Canadians have talked about this. And one of the things they've pointed out and reported in 22 was that the discussion that we have as primary care, looking and talking to the people who are advising us, it just feels like it's toxic. It feels like it's adversarial, and it creates a distorted picture. So some of us find the information from the government useful. Sometimes it's difficult, but we've got to find our own source that we're comfortable with. And as we do that, that dialogue, that scientific discussion is often seen by the community as something that means that no one agrees or no one actually knows what's going on. We probably agree on 95%, but there's a bit that we don't agree on. And the Canadians ended up losing the confidence of their community. Looking at other messages from overseas, there's a universal acknowledgement that primary care is adaptable. And I think there's various reasons for that, and I'll look at some of the other information. So reporting in the European Journal of General Practice, there's some interesting interactions with COVID. There was improved access, and some of that's really good. And I guess in Australia that translates to our telehealth. But resourcing and information flow is complicated and sometimes not working. Sometimes we just can't get masks. Sometimes the information comes in a way that's not appropriate or complicates what we're talking to our patients, clients and community about. And it's been universally recognised that there's a reduction in the comprehensiveness of the services that we can deliver. In the UK, they also noted that the issues about face-to-face consultation would be better if we can somehow balance the need and the complexities that we have with face-to-face consultation, but also how do we actually do our remote control and maybe less complicated interactions. And it was noted there that there is a reduction in the quality of care if it's shorter. And then the question comes about how important is it that the patients are actually talking to someone they know, or is it something that they can just see anyone? And their data says that it is better and easier if it's someone that they actually know. And obviously we were learning right from the start how much can we safely deal with on the phone and remotely what risks are we taking? And for any of you who were involved and active at the time, you were just thinking, what have I missed because of our previous way that we practiced? But again, it was agreed that primary care, so that frontline, is absolutely critical. And if that's working, then there's something to build a response on. It was also noted that primary care was highly adaptable. And the way I read it is that if you've got a strong, well-educated frontline force with the right equipment, you can adapt. You can actually make your own decisions. But if you don't have the autonomy and the strength and the confidence to actually do that, then the system falls down. You need the proper equipment. You need to be supported, and repeatedly, and most of us in Australia are seeing it as well, if it's not financed properly, it doesn't have a very good future. Again, in Europe, it was seen that primary care has a key role to play during and after. And this is where it gets interesting. And I guess we cross the fingers that maybe people will listen to some of this experience. But not only is it our job to translate the white noise, but it is important that we continue to identify risk groups, but we also, on the front line, are monitoring compliance. So we have the capacity to adjust to the needs. So sometimes they're not just a 10-minute consultation, but they're an acute event that needs to be moved somewhere else. But also we can keep monitoring on this tail because COVID's still around, and it's important that we continue to be able to know what's going on. And then the Europeans are saying maybe a unique policy window to convince government to enforce and to support a better public health policy with primary care involved. I think it's a maybe because none of us think it will happen. And then perhaps what could have been. So a report in Medical Journal of Australia, the gaps that have shown up is that telehealth has got its place, but how does it support chronic disease management? What's its place in self-management support? How is it actually identifying and actually supporting those at risk? Have we damaged some of the relationships between the acute and community sectors? And so are we working better with our emergency department colleagues, or has it created some barriers? And is it actually going to lead to constructive model, maybe funding models? Those of you who've used telehealth, so most people can actually use it. At the moment, we're still getting about 2/3 of our consults virtual. And about half of people are saying that they will still continue to use the virtual visits. But sometimes our patients don't have access to the same things. And those of you who've spent half an hour trying to convince somebody that you can actually do a video conference, but it doesn't work, they don't know how to press the buttons, or the person in the house knows how to turn it off, but not how to turn it on. And there are parts where it's not reasonable or fair to think that you can talk over the internet. And we're still struggling how to integrate our health records. And reports have shown around the world that in rural areas it either doesn't work, but in urban areas it's perhaps overutilised. So finding that balance is a challenge. And one of the big deficits is that a lot of the work we can do is to tell our patients how to look after themselves, how to be comfortable about their self-management. So to manage hypertension or heart disease, someone's got to be fit, talk to them about their exercises, their programs, their eating habits. When we defaulted to telehealth, there was nothing about self-management. It was about just dealing with the acute encounter. So there's a hole there that we really need to work out and think through. It was identified early that we need to find people at risk, but during the pandemic, we repeatedly got stories about nursing homes that weren't vaccinated, or facilities where disabled people were not getting their vaccine. So even though it seemed pretty easy to do it, there is a role for frontline workers to actually be proactive and to be supported to actually do it. So some people are getting delayed healthcare. We start to hear the stories now about people who were too afraid to come to the doctor because they're scared of catching COVID, or they think everyone's under pressure, so they're avoiding contacting where actually they still need to be. But frontline is about knowing your patients, knowing who are at risk, and actually being able to respond and looking after them. And you need to be, and we need to be supported so that we can actually still look after them. Identified around the world is this feeling that the linkages between acute and community sector is probably damaged or is undergoing a re-evaluation. And there's a huge concern that will continue to be a risk in systems such as Australia. And the BMJ talked about this feeling that anyone's good in a storm, and so anyone who's available for medical advice is good enough. And so it's actually created a situation, you just need to ring somewhere, look online, and suddenly you can get a script or a bit of advice. It's like, doesn't matter who it is as long as you get the advice. Doesn't matter about the quality or whether you know. And it's seen to create a huge problem for us in the future. And obviously the effect on continuity of care is going to be huge. It's going to mean we're living in a reactive world. And those of us who live in the immunisation and vaccination world, as a model of prevention, makes a huge difference. We can see the potential difficulties. And again, repeated a discussion around, it's given us a chance to think about our funding models, but is it actually going to happen? Are we actually going to get better funding models? So in summary, it's agreed around the world that primary care in the frontline is a cornerstone, needs to be functional for a pandemic response that is worthy of what we invest in our health system. And it has shown that it is highly adaptable to meet the demands of a pandemic. To do that though, the frontline needs to be well supported, well equipped. The training needs to be such that everyone's confident to make decisions because they know that they're trained and supported to do it. But importantly, it needs to be funded. And to do that, it needs to be primary care, and our experiences needs to be included in future planning. Make sure that we're actually still integrated with population and public health programs. And that should be breast screening, bowel cancer screening, any other community public health programs, but also not to lose our association with the acute care sector, because it's important that we can transfer patients on when they're sick. If primary care has got sufficient status, it can continue to be agile and flexible so that it can deliver. In the future, well, is it dawning? Is it setting? And it just lingers on. So thank you.